students and our faculty. We are into the second webinar of the second module in discussing muscle-invasive bladder cancer. And tonight we are going to discuss radical cystectomy, the gold standard in the management of muscle-invasive bladder cancer. We have four very eminent speakers tonight, and I'll introduce the four speakers. We have Mr. Rehan Sohail Khan, consultant urological surgeon and a robotic surgeon and clinical lead with interest in urological cancer in Lanarkshire, Scotland, and he is going to take up the robot-assisted, he is going to talk about the complications of radical cystectomy. Johar Raza, who is a consultant urologist at Henry Ford Health Hospital in Detroit, Michigan. Again, he is going to talk about how to tackle with these complications. Mr. Sarfraz Ahmed, who's a consultant urological and robotic surgeon and director of robotic surgery at Sheikh Shahbut Medical City in Abu Dhabi, is going to take up robot-assisted radical cystectomy. Dr. Nadeem bin Nusrat, a consultant urological surgeon at the PKLI in Lahore, Pakistan, will talk about open radical cystectomy. So without wasting any further time, I would request Mr. Nadeem bin Nusrat to please share his screen and start with his talk. Dr. Nusrat, the screen is yours.
Thank you very much. I hope you can see my screen and you can hear me clearly. Is that okay?
Yeah, your screen is visible. If you can go into the presentation mode, I think we'll see the full screen. Perfect. Thank you.
Yeah. So thank you very much, everyone, for being present and for being patient. I would especially like to thank you, Professor Dr. Hamad Athar, for the kind invitation. My name is Dr. Nadeem Nusrat. I'm a urology consultant at PKLI Lahore, and I have no conflict of interest and any conflicts to disclose. I'm going to briefly talk about the open radical cystectomy. Before I talk about the radical cystectomy and its techniques and the modalities we have, I would like to emphasize why do we need such a major undertaking, and for that we need to know briefly about the disease, and that we call bladder cancer. In cancer, we all know that the cancer behavior, and more specifically and scientifically speaking, the natural history of the cancer is very important, because that tells us the nomograms, which predicts and projects the outcomes and also the outcomes of our treatments, such as the survival benefits. We also need to know if there's any alternatives available to us and to our patients, and the modalities we use to treat this cancer. I will mainly focus on the open technique of performing radical cystectomy, and I will also briefly show a slide of our own indigenous local data we have and we have performed, because it is very important while you're talking and counseling your patients about cancer, you should always present your own data and your own outcomes. And I will also, in the end, I will discuss briefly the challenges we have in dealing with the disease in terms of cultural barriers and the social inhibitions in our country and the culture, and the recent developments and what we need to develop. So briefly about the bladder cancer, we all know Mansoura, the place where we have the most of the cancers presenting and being treated. So the first bladder cancer was diagnosed in Egypt, and obviously with the visible hematuria. The first radical cystectomy was performed in Germany in 1839 and between 1913. It is 9th most common cancer globally. And in this slide, we can see that there is 7.1% rise in the bladder cancer. So instead of being aggressive and progressive, it has increasing incidence. Males are more affected as compared to the females, and the reason being the risk factors involved. We all know the smoking, occupational hazards or exposure involved, and other correlative risk factors are involved in the disease initiation and the progression. The initial management is very straightforward in bladder cancers. Visible hematuria is the presentation in a CT urogram with a flexible cystoscopy is the way forward to diagnose and start the initial management, which is the TURBT we start with. Types, urothelial cancer, which we call transitional cell carcinoma, is the most common. And this amounts to about 90% of the cancer we deal with. Squamous cell is another presentation. Adenocarcinoma is the third type, the commonest type. This slide is showing the management algorithm. It's a busy slide. I will not go into the details of this slide. However, it is showing the surgical approach, the initial surgical approach, and then it is also showing the systemic therapies and the emerging therapies, the novel therapies in the management of bladder cancer. Radical cystectomy, especially the open radical cystectomy, which is my topic today, talking about the indications, the first indication of the patient being fit in terms of its ECOG, which is the performance status, and an aesthetic evaluation in terms of ASA, the willingness of the patient to have the procedure after full counseling. Age is not an issue. We always calculate life expectancy of the patient, and then we offer them the treatment. Muscle invasive bladder cancer is the mainstay of the management for an open radical cystectomy. You can always start with the T2 to T4A-N1 disease. There is certain controversial areas, and not controversial to me, because when I counsel my patients, I always consider and include these categories in offering upfront radical cystectomy, which is T1, G3, especially if it is refractory to the BCG treatment, carcinoma in situ, especially when it is multifocal and it is refractory to the BCG treatment. Superficial tumor, however, if it is multifocal and frequently recurring, and if the bladder is full of tumor and the complete resection is not possible, and then it recurs, so that is also an indication to offer the patient cystectomy. And if the patient has non-invasive muscle cancer, but as I've said earlier, if it is frequently recurring, if the bladder is full of tumor, if it is unresectable, and the patient is getting frequently symptomatic, he can be offered this treatment option. Radical cystectomy, talking about the procedure, involves removing the bladder, and then removal of prostate we'll briefly talk about, removing the urethra, and the vaginal reconstruction, if possible, if the patient asks for. In terms of nodal management, the internal iliacs, the external iliacs, the common iliacs, more proximal nodes can be removed if enlarged during the surgery and found enlarged, not from the prognostic point of view, however, from the sampling point of view. The third part of the procedure in an open radical cystectomy is a reconstructive part. And in the reconstruction, we have three main options: the continent type of diversions or the reconstructions, the incontinent type of reconstructions. And incontinent, we have two types, the catheter and the non-catheter. And the third type we have is an orthotopic, in which we just reconstruct the bladder on a continent urethral sphincter. We take different parts to reconstruct the bladder, including the stomach, jejunum, ileum, and the colon. In the neobladder, there's W pouch, there is a Studer pouch, Indiana pouch, and previously in the past, I don't do this anymore, uretrosigmoidostomy. Moving on, the technique has different approaches, I would say, apart from being salvage or partial or the radical. Nowadays, as it is emerging in the prostate cancer, role of cytoreduction. If there is a single foci of metastasis, can that be removed with the bladder? Does that has any survival benefit or not? It's a controversial area. The studies, small studies, have been presented and been published. However, talking about the approach, it can be extraperitoneal and intraperitoneal approaches. Both are established, very well used. Antegrade means start from the prostatic part of the urethra and coming back, and the retrograde means that we go opposite way. And all three options are available: open, laparoscopic, robotic. At my institution where I work, we do not offer patients laparoscopic. Either we do open or robotic. I mainly offer my patients an open radical cystoprostatectomy. In terms of surgical technique, and the debate can be around the use of energy devices for dissection that saves time and saves blood loss. For anastomosis, hand stitching, or the use of the staplers. The conduit length is a controversial area, where we are doing this extraperitoneal approach, because we don't mobilize the ureter across the midline. So in that particular case, we use an extra conduit, the length. There is debate around the uretroileal anastomotic techniques and the use of the double J stents or the single J stents, the conduit catheters to be placed to keep the conduit empty to reduce the pressure during the healing period, how to minimize the metabolic challenges during the recovery and to avoid the long-term complications. And also in the cases when the patients are unfit to have the bladder removed or their bowel to be used, can we offer such patients a cutaneous uretrostomy? There are certain pros and cons. There is no right and wrong. There is no hard and fast rule that this is right and this is wrong. And luckily, I would say that there is no strict guidelines or evidence-based things that we can say, well, look, this modality is superior and another modality is inferior. There is pros and cons to each modality, and whichever modality you feel safe to perform, I personally always go for that modality. I'll not go into the details of an open surgery, laparoscopic, or the robotic surgery pros and cons debates, but all three options are available to the patients. In terms of uretroileal anastomosis, I personally, and I've seen most of my trainers use the Bricker's technique, and it has its own pros and cons. And the other technique was the Wallace technique, in which we join both the ureters and we do an end-to-end anastomosis rather than side to side, which we do in case of a Bricker anastomosis. Indiana pouch, few of my colleagues do use this approach, and they feel that they are good and they feel safe, and they have their own pros and cons about this procedure. I normally offer both of these approaches, which is neobladder and ileal conduit. In majority of my bladder cancer patients, I offer them conduit. However, if they are suitable candidate, such as if there is no extension of the tumor at the bladder neck or the prostatic part of the urethra, and if they can take the metabolic challenge, if they are educated, they are motivated, they're prepared to do an SIC or the Credis maneuver, and they are okay with to deal with the metabolic challenges, I do offer them either a Studer pouch or a W pouch. As I've already said, ileal conduit, neobladder, and Indiana pouch both have their pros and cons. I'll again not go into the details because of time constraints, because I'll have to move on and to complete the topic. The metabolic impacts, we all know, it depends which part we use to reconstruct the bladder. In case of neobladders, we normally use ileum. However, the stomach, jejunum, ileum, and the large colon has been taken, and each part of the bowel has its own metabolic characteristics, and that is the way they impact the outcomes and post-operative metabolic challenges. MDT is the key in terms of risk stratifying the bladder cancer and its management. Follow-up needs, it depends both like the radiological and the laboratory, and also the patient satisfaction. And in some cases, I've seen my patients coming back after the neobladder and they request for a conversion to ileal conduit, and mainly they're not happy with the bladder emptying and they're not happy performing an SIC. Role of neoadjuvant chemotherapy. Again, it has a documented survival benefit in dealing with the micrometastasis. I normally offer all of my patients a consultation with the medical oncologist, and if the medical oncologist feels appropriate and there's no time constraints in terms of delaying the management, we do offer them neoadjuvant chemotherapy, and we do evaluate them in the middle and after the chemotherapy, and then we offer them radical cystectomy. Salvage cystectomy, as you all know, very challenging technique because patient after chemo has had radiotherapy and the tissue is quite plastered and cemented. It is very difficult to dissect. However, if the patient is still N0, M0, patient can be offered a salvage cystectomy. Challenges in terms of cystectomy and reconstruction. As it has already mentioned, there is 3 components: cystectomy, nodal dissection, and the reconstruction part. It has both its pros and cons, and there is some evidence bases in terms of guidelines available as to which option to be offered to which group of patients. Quality of life, as I've already said, is another area to be considered before offering patients this surgical procedure. And then the main social and the cultural barrier is a lot of patients, they do not go for an open surgical procedure only for the reason that they don't like to wear a bag for the rest of their life, and they do ask for any alternative available to them. Yes, we do have an alternative in terms of orthotopic pouch. However, the orthotopic pouch is a subject of careful case selection. And if I feel in my cases that the patient is not metabolically suitable for having an orthotopic pouch, I do counsel them. And if they accept that advice, I offer them a conduit. But again, it is challenging. And therefore, most of the patients, first of all, they present very late in the course of their disease, and they're T4 or T4A, N1, or even just before N0, M0, or T4, in which case it is very difficult to offer them an orthotopic pouch because there's a higher chances of having radiotherapy in a post-operative settings. We all know we do cystoprostatectomy because 20% of the prostates has cancer in the prostate, either low risk or a higher risk. The role of urethrectomy is again controversial. If the prostatic urethra is involved, I do counsel and offer my patients urethrectomy. It will just add 45 minutes to an hour in the surgical time. However, if we cannot offer patients urethrectomy and they do get the recurrence in the urethra, and then we'll check, urethroskopy is advised. As I've already mentioned, I always prefer to quote my own data and the results. This slide is a busy slide, but in the last 3 years, we have performed almost 80 cystectomies. So whenever I counsel my patients, I offer them my own data, and I talk about this data which I have in front of us, and I quote my own, the results, outcome, and complications. And nevertheless, I do tell them that most of 80% of our patients are T4 diseases. Now, early versus late is always a dilemma, especially in a country like Pakistan. I've already discussed this. I always advocate centralization of care, because this gives you the frequency of the cases, and it's also good for the trainees because they can have a better exposure. Instead of having two cases in a year's time, you can have 2 cases every day or every week. The registry will lack this in our country. I think I always emphasize this. We need to have a national cancer database so that we can have nomograms the way we have internationally. Public health awareness, the things I have discussed previously, such as the cancer registry. I think the most important thing is to have the public health awareness and the professional health awareness campaigns through which we can make people aware of the disease and its treatments. And then I've already mentioned about the gender distribution, the complication. There's a short-term and the long-term. Long-term complications are mostly associated with around the stoma and the urethroileal anastomosis. The take-home messages that the radical cystectomy in a carefully selected patient is a life-saving procedure. I have a few references there, and with this, I end my presentation, and thank you very much. And I think I just leave it to Professor Hamad if there's any question to be addressed in the end of the conversation. Thank you.
Thank you, Dr. Nadeem. It's a very comprehensive talk, and I think you've touched upon all important areas. It's important that we should know that this is a very complicated, probably one of the most complicated surgical procedure that we do, and there is a learning curve. So it's important that we discuss cases with our peers who have a far greater experience before embarking upon. So if there are any questions, please, you can write them in your chat box. And if you want to ask verbally, then you raise your hand and the administrator is going to open your mic so that you can ask your question. So at the moment, I have addressed 2 questions, and Dr. Nadeem can review those questions and answers, and maybe if you'd like to add a comment. We now move on to our next presenter, and it's my pleasure to introduce our next presenter, who is Dr. Sarfraz Ahmed. He's a consultant urological robotic surgeon and director of robotic surgery at Sheikh Shahbout Medical City in Abu Dhabi. Very extensive experience of bladder cancer with radical and open and robot-assisted cystectomy. So he's going to talk about robot-assisted radical cystectomy tonight. Sarfraz, this screen is yours. I'll unshare. You can share your screen.
Okay. Thank you, Professor Ahmad, for the invite, and really congratulations on organizing this important course for the trainees in Pakistan. I have already shared. Can you see my slide? Let's try again. Can you see it?
Yes, we can. Please proceed.
Thank you. So I'll be talking about robotic-assisted radical cystectomy. Dr. Nadeem bin Nusrat has given a very comprehensive view about the bladder cancer, and this actually helped me to skip few of my slides. I have no disclosure relating to this talk. So what I'm going to discuss today, the first thing is that we know that open radical cystectomy is a gold standard. and has been gold standard for a while. So why we need a robotic cystectomy and what evidence we have. And at the end, I will discuss few technical steps which we use to perform robotic cystectomy. So for the goal of any oncological surgery, and specifically for the radical cystectomy, we want to do a procedure which is safe with a faster recovery. Additionally, we want to get a cancer cure and also good functional outcomes. But this is not simple because it is a complex procedure. And in fact, it is not a one procedure. It is a combination of three procedures: cystectomy, lymph node dissection, urinary diversion. And additionally, there is a complexities because the procedure is different in male and female population. And we also deal with the disease-related and patient-related factors as well, which will make this procedure even more complex. And we also deal with the aging population, advanced disease, which contribute to the complexity of this procedure. Today's talk is mainly focused on the cystectomy part of the whole procedure, and this will be the focus of my talk as well. If we look at the evolution of surgical technique, Dr. Nadeem has already referred that open cystectomy is there for a while. Then we went to minimal invasive in early 90s, and the robotic cystectomy started in 2003, and since then it has been popularized. So why we need to do minimal invasive surgery? And especially if we have established open cystectomy, which has been doing the job for a while, so why we need to proceed to get a new technique? The main reason is that we are looking for something which is a bit more safer or providing more better oncological and functional outcome. This is the aim of having some additional treatment. And this is what robot has to compete when it's need to take the place of the open cystectomy. So we need to know like why we need to change, because we want to reduce the morbidity associated with the open surgery. We want to have better oncological outcome and better functional outcome. And we need to make sure that it is an effective method which can be replicable so that we can train the next generation as well. Robotic cystectomy is around for nearly around 25 years now. And since then, there is a lot of data available. If you look at what is the evidence behind the robotic cystectomy, we have many case series. We have systematic review, meta-analysis, comparative study, and we have multiple randomized trial as well. The first question is that, is this safe and to provide oncological benefit as compared to the open? So many studies, including the one paper which I just mentioned on the slide, have highlighted that the result of oncological outcome is comparable to open surgery, short-term and long-term. So this has been established, not only the comparative study, but also the randomized trial, which I'll be mentioning shortly. If we look at what is the outcome of systematic review and meta-analysis of comparative studies, so one thing is clear that the surgical margin, lymph node yield, it is same between open and robotic assisted, but the robotic assisted is superior in terms of reduce a need for transfusion and blood loss. High-grade complications are reported less in the previous meta-analysis of comparative studies, and also length of stay. The one thing which is consistently not in a favor of robotic cystectomy is a long operation time. If we look at the meta-analysis of a randomized controlled trial, so there was an older study nearly 8 years ago, which compiled the data from the 4 randomized controlled trial. But in this study, the comparison was between the robotic assisted cystectomy with extracorporeal urinary diversion and open radical cystectomy. But it again showed that the length of stay, lymph node yield, positive surgical margin, 90-day complication, and quality of life is same as open surgery. But the robotic cystectomy was better in terms of need for blood transfusion, wound complication. And again, we noticed that operation time was consistently higher or longer in terms of if you compare to open surgery. So there has been criticism on these previous studies that we are not comparing true minimal invasive with the open surgery, because most of these studies which I mentioned, they have actually compared radical cystectomy was done as a robotic, and the conduit was, or the new bladder was done open technique. So it was not the true minimal invasive comparison. So to address this, we have now randomized trial, which is comparing total intracorporeal urinary diversion and compare with the open surgery. This is Italian study which is published this year to address that if we compare open radical cystectomy with total intracorporeal radical cystectomy with ileal conduit, what will be the outcomes? They focus on 4 things. One was the transfusion rate. The other was preoperative and postoperative complication, 3 years oncological outcome, and the cost analysis. So what they found that the transfusion required for the robotic cases was superior in radical cystectomy, which is consistent with the previous studies as well. The blood loss was also low in the radical robotic assisted cystectomy, but the operation time was longer, which is statistically significant. The rest of the perioperative parameters were both the same in open and radical cystectomy. The cost again was found to be higher in statistically significantly higher in robotic cases. So if we look at what were the oncological outcome at the end of 3 years, so there was no difference. The cancer-specific survival, overall survival, metastatic-free survival, disease-free survival, they were same in both groups, which indicate that robotic is as safe as open surgery in terms of achieving oncological outcomes. So they concluded few points like that transfusion rate definitely reduced to 50% in robotic cystectomy. Complication rate and oncological rate were comparable with open surgery. Patient with a minimal invasive have a better body image perception. And the patient who underwent continent diversion, they have the same daytime and nighttime continence recovery as compared to open and robotic. And that the cost remain a major drawback for the robotic surgery. Similarly, the UK trial, IROC trial, which look into the patient who are alive at 90 days and out of hospital, was noted to be statistically superior in robotic cystectomy. This trial was concluded a bit early due to COVID, and we don't know what will be the long-term effect of this survival advantage of the robotic cases, but the later study may confirm this. This may prove to be a significant in terms of survival benefit. So to compile now, we have recently this year, we published now new updated randomized the meta-analysis and systematic review of 8 randomized controlled trial, which included nearly 1,000 patients. This study revealed that there is operation time is again higher in all these randomized controlled trial in robotic cases. Blood loss was less. And in terms of length of stay was marginally better in the robotic cases. The rest of bowel recovery, lymph node yield, positive surgical margin was equal in both groups. So what we see like that complication rate, oncological outcomes, they are equal in both groups. Transfusion rate is better in term of robotic assisted cystectomy. Operation time and the cost is again a persistent factor in robotic surgery. Quality of life is similar in both group at 3 and 6 months. So because the data is now quite mature during the last 20 years, if we look at the guidelines, the European Association of Urology clearly recommend a strong that a patient need to have a discussion about a robotic assisted cystectomy as an option. Obviously, this need to be done in a center where the expertise exists, and high volume centers have shown to improve outcomes of robotic cystectomy. Similarly, AUA also recognize robotic assisted cystectomy as a surgical options, but emphasis is on that we need to have long-term oncological outcomes and quality of life measures are required before wider acceptability of robotic cystectomy. So what we have seen that the cystectomy evidence has matured enough, and there has been a trend that this has been adopted in many centers, especially Western countries, is now challenging the open surgery, and most of the center now replacing where the expertise exists from open to robotic assisted. And in fact, from 2006 to 2008, it was used in 29% center in America and European center, which is now increased to 54 center until end of 2018. And there is a even further increase in adoption of robotic assisted cystectomy. If we look at like initially, the most of the conduit or diversions were done by extracorporeal approach, but now there is increasing trend. And as the expertise improve, most of the surgeons are moving toward total intracorporeal diversions as well. So let's see what are the surgical steps. So if we look at male and female, there is a slightly different steps. So I'll go through the male robotic assisted cystectomy, how we approach, and what are the main steps. Whatever procedure or technique we use, we need to stick to the basic principle of oncological to improve cancer clearance. That will be the key, whatever technique we are using, open, laparoscopic, or robotic. So the first thing is that the position. So this is the normal position which we use with the older version of robot. The newer version slightly, we don't have to put the legs in strap, and we can put on a straight on the table, but the position will be the same Trendelenburg position. Patient need to be fit enough to sustain this position for a longer period of time. And we need to have a lot of discussions with anesthetists to make sure there's a safe positioning throughout the procedure. The standard port position, this is for SI robot. We use 6 ports, 3 robotic and 3 assistant port. So I put normally 2 12-millimeter port on the right side, left side of the patient, which will help me to use a stapler for the urinary diversion. The first step is to identify, this is slightly different the way we use our open technique. When the bladder is still attached to the anterior abdominal wall. So this is the first step, that go and find the right ureter by incising the peritoneum, and it's very easy to identify. The right side is done first because it will allow sigmoid colon is still attached on the left side, so there is a lot of space there, so you can start dissection there. So we need to preserve a good amount of periureteric tissue, and make sure we do good mobilization. In robotic cases, we don't have to really need to go very close to bladder, because most of this part below the level of pelvic brim, we don't need when we are, especially if you're doing the ileal conduit. To make sure like you have a good margin, especially if there's a worry about upper tract involvement in the distal part, so good margin, and we normally secure with the stapler, with the hemolock. After doing the left ureter, the next step is to go posteriorly. Again, this step is done while the bladder is still attached with the anterior abdominal wall. The peritoneal incision is made, and we will just proceed the incision, mostly using the blunt dissection, but very specific area we use diathermy just to minimize, just to make sure there is no damage to the rectum. After opening the non-various fascia, drop down the rectum using mainly blunt dissection. And while lifting the bladder up, you can use your assistant or the fourth arm to help with this mobilization. So once you have mobilized posteriorly enough, try to go as far as you can go. The most of the job is done now. Then the next step is that you need to make a space laterally, not to draw bladder completely at this stage, just lateral to the medial umbilical ligament. We make incision on the peritoneum, and we will extend this dissection, usually done by blunt, and keep going to the lateral pelvic wall and dropping the bladder down as shown in this picture. The bladder is here. And then you can thin down the pedicles, which is shown in this rectangular box. So now if you can imagine like that, your bladder is now posteriorly mobilized, you have lifted off the rectum, and laterally you have lifted away from the pelvic wall. So all you left is a pedicle in front of you, which you can secure using hemolock or a vessel sealer, whatever is your preference. Usually I use hemolock to secure the pedicles. Once the pedicle is secure, then the easy job is to drop the bladder from the anterior wall. There's a urachus. You can just divide that. This is the part which usually the first step which we ask our trainees to do. It is less risky, and it gives a good confidence for the trainees at early part of their training curve, learning curve for the robotic cystectomy. So once you have dropped the bladder completely, it is important that you mobilize the urethra, especially if you're doing neobladder. So you need to preserve good amount of length on the urethra. Not to cut blindly, but it is important to put a hemolock clip before dividing to avoid any spillage from the bladder. which can cause a local recurrence if it's not carefully applied. So, and another thing is that there was initial criticism on robotic cystectomy. There was some issues with the spillage. So whatever specimen we are removing, either it's bladder or lymph nodes, we need to put in a bag to prevent any spillage of the cancer cells. So how to retrieve specimen in a male specimen? This is one of my patient, which I normally extend one of the assistant port incision, which is on the left side. You can see the left lower one. After placing a specimen in bag, you can retrieve through this area, and which is quite nicely done. Some people use supraumbilical one, but my preference is one of the assistant, which help to retrieve specimen easily. And if we look at the female, there is a slightly difference. Like when we go initially, you can see in front of you ovaries and ovarian pedicle. I normally divide these one, mobilize ovaries, then go to round ligament of uterus, and then you can identify the ureter as you have done with the male patient. So clips are applied on the ovarian pedicle. Your mobilization is done on the lateral side. Then the next step is to lift up the uterus away from you and go in pouch of Douglas to make an incision. At this stage, if you can put a sponge on a stick inside the vagina, which will help to identify where you need to make an incision. This is shown in this picture. There's a sponge on a stick, which is open vagina. You need to stay anterior to this area, and then the lateral pedicle can be dealt with the hemolog. So the specimen in female, we retrieve through the vagina. Once the vagina is open, the specimen is placed in a bag, and you can retrieve through vagina, and the vagina is closed after that to prevent air leak from the vagina during the procedure. So there are a few things which can cause a problem during robotic cystectomy. The one is that patients are usually obese. They can have multiple operation. So we need to be careful about these patients to avoid any adhesion. If you have a laparoscopic training, that help normally to put initial ports. It is not a contraindicated if patient has a previous surgery. You can still do a robotic cystectomy in a patient with the previous surgeries. The bulky tumors are a bit of challenge. Like if you can see this patient, there is a quite large tumor involving whole of the bladder, and actually the bladder is coming out from the pelvis into the abdomen. In these patients, you don't have any space posteriorly to lift safely from the rectum. So they may not be very suitable, especially in the early learning curve. Previous surgeries can pose a problem, but these can be managed if you have a laparoscopic skill. So you can divide this adhesion before putting ports. And then we have some time if there is a synchronous tumors in upper tract. So we have done a few cases where we have to do nephrouretrectomy, unblock with the bladder and prostate. So this can be done as long as you have expertise to do the upper tract robotic surgeries as well. So now we'll see like why robot is becoming more common, especially if the cost is not an issue in many centers. Then it is helpful for surgeon because we can get a very good 3D magnified view. We can have wristed movements of the instruments. It is very intuitive. It's working is make life quite easy, especially in a difficult area where normal laparoscopic instruments struggle. And then important factor is that especially if we look at the more complex procedure, it is comfortable for surgeon. We are sitting and we can do longer procedure without having any physical exertion. It is definitely less than what we experienced during the open surgery. And it is also very helpful, like we can train the newer generation of doctors when we have a dual console. There is a modular pathway to train. So there is advantages for the surgeon, not only from the vision improvement, but also from the training perspective. So if we look at what are the benefit for the patient? So we know that less blood loss. We have shown in a study that shorter hospital stay, equal oncological outcomes, and less complication reported in few studies as well. And pain, of course, is less because of the minimal invasive nature. So bottom line is that like robot is one technique of doing a cystectomy. As a surgeon, like you need to choose what is the best for you. If you are trained in robotic surgery, you find this is the best approach, we should use that. If you're trained in open surgery, you should do open surgery. There is no right and wrong. The evidence is now mature enough, showing some advantages with the robot. If the cost is not an issue, many people who has moved from open to robotic, they don't want to go back to open. They want to continue with the robot. But the bottom line is that, like, we need to choose what is right for our patient. One thing for all the younger urologists, that the technology will keep advancing, so there is no going back. So we need to be open and accept what is coming our way, but also need to be aware that we need to adopt things which has strong evidence, and not to adopt things without having strong evidence before we can apply in our clinical practice. The training is very important, so we need to train ourselves best, spend time on initial years of your life so that you can train and then apply these training for the improvement of your patient. That's all, and thank you very much. If you have any question, I'll be happy to answer.
Thank you very much, Surfraz. I think it's a very comprehensive and a very balanced talk on robot-assisted radical cystectomy. Important thing is that you choose your surgeon in your center rather than robot versus open, which is, I think, the key message. So it's important that if your center or your surgeon does not have good experience with robot, open is nearly as good. There are questions which you probably can address online in the chat box. And if there are some other questions, we can take it in the end. So thank you very much, Surfraz. You can unshare your screen, please. Okay. Our next speaker is Dr. Johar Raza, who's a certified American Board of Urology urologist at Henry Ford Health Hospitals in Detroit, Michigan. He is going to talk about how to minimize complications in radical cystectomy. Johar, the screen is yours.
Assalamu alaikum, Dr. Ahmad, and all the participants. I hope you can see the screen.
We can see you, which is better than the screen.
Can you see it now?
Not as yet.
Not yet.
Prof, we can see it for some reason. I think it's visible.
Okay.
You guys can see?
Please proceed.
Yeah, I think maybe I was having the same problem. You have to click on the share screen on the Zoom if you want to see my screen. Anyways, so Bismillahirrahmanirrahim. Assalamu alaikum, everybody, once again. Thank you, Dr. Ahmad, for this opportunity. And very near and dear topic to all of us. We all get excited when we see a cystectomy coming across getting admitted. But the biggest problem is that cystectomy, has already been alluded by many of the presenters and by Dr. Ahmad himself, is that it's not an easy surgery. It's a very high-risk surgery, one of the leading rates of complications. So we need to learn how to minimize these complications. And I'm going to talk about those with some literature, some personal experiences, so that we can learn a little bit together. Now, I don't have any disclosures for this talk. I unfortunately haven't done a lot of open cystectomies, especially since I've moved to US. My last open must have been like 10, 12 years ago. But I think the principles still remain the same. And the key things that we need to understand is that, as Dr. Surfraz mentioned previously, that there are three parts of the process. There's a procedure of cystectomy, there's a procedure of lymph node dissection, and there's a procedure of urinary diversion. And I think primarily the complications arise from the urinary diversion part. And those are the ones which sort of drive your post-operative course. Whereas the extrapolative part, which is the cystectomy, usually does not have any major complications unless there are technical issues with your procedure itself. So those are the things that we will just review quickly. But I will be talking about some preoperative factors, intraoperative factors, and some postoperative factors that can help you minimize the complications. One major thing that I would highlight here is, and as Dr. Ahmad, I think, alluded to, is surgery case volume is very important. So and a lot of data has convinced us and has informed us that high volume operating centers are associated with better outcomes and less complications. And I think one thing which is very important, whoever is taking up this task in their new job or new institution, they need to streamline the whole process. Create teams, especially when you're talking about robotic cystectomies or robotic surgeries. You have to have a very dedicated team that is going to lead you throughout the case. So you need a preoperative team, you need an intraoperative team, and a postoperative team to make sure that you have a streamlined approach to it. So when we look at the complications, like I said, they can be pertinent to radical cystectomies, cystectomy part itself, anesthesia, long procedure. So you can have atelectasis, pneumonia, fluid overload. These are generally sick patients, so they can have other medical comorbidities which can make it difficult for them to tolerate the procedure and can have an untoward event. You can have a vascular injury. You can have any postoperative bleeding from the pedicles or from the DVC. You can have infections, dehiscence, DVT, PE. These are pertinent complications. Then there are complications which are pertinent to the diversion itself. You can have anastomotic leak, whether it is bowel or urine, urethral anastomosis. You can have infections. You can have pyelonephritis, sepsis, wound infections, and all that. And one key important complication is development of ileus or GI complications. So these are the things that you have to be aware of in the short term. In long term, there can be other stoma-related complications. There can be metabolic issues. You can have strictures, ischemias, or infections, and also tumor recurrences in the long run. With regards to lymph node dissection itself, lymphoceles are very commonly seen. These can be non-infected or infected lymphoceles. You can have a nerve injury or a vascular injury at the time of lymph node dissection, and you can also have lower extremity edema after lymph node dissection, which can predispose you to development of deep venous thrombosis. So this is a little capture of the complication rates complication summary. When we look at the radical cystectomy complications pertinent to bleeding, you can have two major sources. You can have DVC bleeding, or you can have a vascular injury either at the level of the pedicles or while you're doing the lymph node dissection. For DVC itself, I think it's a bit of a challenge, especially when you're doing open surgery. If you've not been adequately trained to do a DVC control with by the use of when you do radical prostatectomies, it can be a little bit of a challenge. But a couple of things that can really help you is you should have a very decent, adequate mobilization of the apical tissue, which is more medial from the direction of the opening of the endopelvic fascia. So that's important. And try to mobilize as much as you can, thin out the DVC as much as you can. I would personally recommend to transfix the DVC rather than to throw a tie underneath. There are more than one ways to skin a cat, but transfixation is preferable. If you can afford and you have decent affordability, utilization of a vascular stapler, a white load stapler, is also helpful. That you can control the DVC directly with that as well. You have a bit of a benefit, especially if you're not doing a neobladder. You have a bit of a liberty to cut deeper into the urethra, even if you fire a load across the urethra, which usually doesn't happen because if there is already a Foley in there, we are very unlikely to come across the urethra from that standpoint. Even if that it damages the urethra, it's not a major concern, but it'll get you a decent control. Again, the benefit is with a thinner DVC, you will be able to get better control. When you talk about vascular injury, it can happen at the level of the pedicle. So again, you can use a stapler to prevent vascular injuries there. You can oversew the pedicle as well. You also can encounter these vascular injuries at the time of lymph node dissection. So review your imaging appropriately. That's very, very important. So pay particular attention to the proximity of the vascular structures or other key structures when you're with regards to the lymph nodes. Another key complication is rectal injury. Folks who have had radiation in the past, who have had prior abdominal or rectal colonic surgery, they are at sort of high risk. Always important to look at the imaging if you have any concerns, especially with a bimanual examination. If you're concerned, always try to go one step further to make sure that you have appropriate imaging and preoperative knowledge that what you would be encountering. So maybe like a pelvic MRI would be a bit more detailed imaging of possible rectal involvement if you have any suspicions on a bimanual examination. More pertinent for men when you're doing a male cystectomy. And in that case, appropriate counseling before the surgery is important. You have to get your colorectal colleagues on board. Next week, I'm doing a cystectomy on a patient who had colorectal surgery done for colorectal cancer some years ago. They also had chemoradiation for that as well. So I've already talked to them and got them on board and pre-counseled the patient so that in case of any untoward event, a rectal injury, they're mentally prepared that they might end up with a diversion, a double diversion. With regards to obturator nerve, that's another part of the radical cystectomy or lymph node dissection area where you can expect an injury. Again, make sure that you identify your landmarks appropriately. And I do robotic surgery, so whenever I see the pubic bone, anything below, I am very careful when I'm cutting or putting a clip across. And what I teach my trainees and I practice myself is that try to identify the nerve first. Once you've seen the nerve, then you can be more liberal with your dissection. If you identify an injury and if it is you can approximate it, it can be repaired. I won't go into that detail, but a key thing to understand is whenever you have an obturator nerve injury, there is a loss of abduction. So you cannot, adduction, you cannot abduct the thigh. That means you cannot externally rotate your thigh. So it's almost like the example is that somebody cannot get out of the car. So if they're a driver, depending on what side of the country you're driving, you can if it's the right side, so right nerve injury, so you cannot get out of the car from the right side, so you won't be able to abduct your thigh. Moving on, this is a systematic review meta-analysis and a meta-regression analysis sort of recently published of all the complications after radical cystectomy. The reason why I chose this is that this is data of like over 44 studies, randomized controlled trials, and that gives you information about what are the most common complications of this procedure. And based on that, you can retrograde, sort of train yourself or work around that what are the most common complications and how you can avoid that. And we'll address some of those as we go along. So the key thing that really stands out here is that if you look at the chart here, you can identify that about 45% of these complications are cleaving grade 3 or less, or actually less than 3. So that's kind of reassuring from that standpoint, that although there is high risk of complications, but major complications which may require intervention, which may require an ICU admission, which may require an organ failure, even death, is relatively less, even in these larger analyses. Most common complications are GI-related complications, and as we talked about, that it's the diversion part which kind of drives the whole scenario here. The good thing about this paper was that they were able to provide specific measurable patient factors which could be related to certain complications, and we'll look at that in this table here. So you can look at the Cleveland classification. So they classified Cleveland grades, and they basically looked at what were the pertinent risk factors that could predispose one to these complications. So in summary, I would say, and you can allude back, you can pull out this paper and look through that, is that any patient who has advanced age or undergoes a surgery for a longer duration are more likely to have Cleveland grade 3 or above complications. So these are the two major risk factors that if you already know about, you can work around it and make sure that those are appropriately addressed. And many other risk factors have also been identified, like number of lymph nodes removed. So that means if you're doing very extensive lymph node dissection, you may end up with more complications. And the recent clinical trial, the SAURC clinical trial, did allude to that as well, that extended lymph node dissection was associated with more complications and did not impact the survival outcomes. Presence of other comorbid conditions, prior abdominal surgery, these are all other key risk factors that can affect your complications. Same is the case, they identify a lot of other genetic complications, system-wise. And I just highlighted the ileus, which was one of the most common complications identified in the analysis, and a history of prior surgery sort of was one of the predisposing factor. And same is the case for other complications noted. So having known that, I think there are a lot of preoperative factors that we need to address or keep in mind when we are preparing our patients for this major surgery, and particular attention to high caloric protein diet. You can combat the surgical stress that is associated. So you can prepare patients with health and nutrition standpoint. There is some data, although one of the trials actually recently proved that there wasn't significant difference, but immunonutrition in certain patients, especially if they're immunocompromised or immune deficient because of old age or other medical problems, immunonutrition drinks can improve their overall nutritional status and can be favorable in terms of their surgical outcomes, and that can be avoided. Tolerable exercise or physical activity, that is also important. So I always address and ask my patients to do a little bit of challenging, if they can tolerate, to do some exercise preoperatively, especially if they have some baseline cardiac issues, or if they have pulmonary issues, or if they have preoperative history of smoking, which is very common in this patient population. And I also ask them to stop smoking, do breathing exercises so their pulmonary functions and stamina overall improves. Patient selection is very important. We have learned through various studies that increasing age, as we just alluded, female gender, obesity, your comorbidity status, whichever criteria you use, ASA or Charlson's index, higher of those or presence of these things can lead to higher risk of complications. So if you're earlier on in this case, you have limited experience, I would strongly recommend that you should refer these patients into expert hands, or have expert help available to let you have you walk through these complex cases. But it's important to take care of these issues preoperatively and have a select patient population. You should always try to utilize some preoperative nomograms that can predict you the outcomes. And one of the most favored one that we use here is NSQIP, which is from American College of Surgeons. There is a risk calculator available. You can plug it on all the information, as you can see here, based on your patient's profile, and it'll give you an outcome with regards to what are the risk of complications, what complications can be anticipated after this procedure, and it also estimates the hospital stay and the risk of mortality after the procedure. So it's a good calculator that you can discuss with your patients preoperatively so that they can be counseled. Some preoperative workup is also important. So make sure that you know their hemoglobin levels, their kidney functions, their nutritional status by assessing their albumin and pre-albumin levels. Be careful about the neoadjuvant chemotherapy, because that can compromise the bone marrow function. So give appropriate time for them to recover from their bone marrow function. I used to wait for 4 weeks, then I've cut it down to almost 2 weeks now, depending on how well they respond, or if they get the dosed MVAC, pretty decently tolerable now. If patients have significant comorbidities, make sure you get appropriate consultations, cardiac, pulmonary, GI, all complications, consultations are very appropriate so that you can optimize your patient in the best possible way before you jump into the procedure. So in my practice, I have a norm that I see patients 2 weeks prior to the surgery to discuss all these things, and the very same day they see our preoperative anesthesia optimization clinic where they are assessed. And anything that needs to be further addressed, I have that 2 week window to address that with their primary cardiologist or pulmonologist, or a new consultation if it is required, to make sure that they are optimized for the surgery. So if you're new in your practice and you're trying to develop a bladder cancer program and trying to do cystectomies, this is something that you would really want to work on and establish. As I told you, that teamwork is very important. Then preoperative preparation is very, very crucial. Enhanced recovery pathways protocol has proven in open and even minimally invasive approaches that it does help with the speedy recovery of these patients. So make sure that all the ERAS protocol is implemented, you follow those points, and ensure that those are executed, especially in the preoperative setting. So mechanical bowel prep is no longer recommended. Patients develop electrolyte imbalances, they get dehydrated, and there is a loss of natural bacteria in the gut, which can predispose them to other untoward infections and issues. So therefore, that is out of practice. Usually 24 hours before the procedure, you put patients on clear liquid diets. That does adequate preparation of your bowel. Make sure you give them prophylaxis for DVT, run the antibiotic prophylaxis just for 24 hours. And Entreg and Albipam is available in the West, but I don't know if it's available in the developing countries. But that's another thing that has proven to improve the cut motility or prevent the ileus. I would strongly recommend that you go on the ERAS website. There is a website. There is a procedure-specific details with cystectomy. I would appreciate if you go through that, and you can get all these points, all these informations, and if you want, you can also refer back to this presentation. Some of the intraoperative factors that can sort of determine your complications are you have to pay particular attention to your surgical technique. I think it's very important, and I think Dr. Safraz also alluded to, is that that when you're doing the dissection, you make sure that you leave adequate tissues around, especially for the ureters. I think when we're doing it robotically, we are so much magnified that everything looks so big, and then we end up maybe staying too close to the ureter, and we end up causing a little bit of periureteral tissue damage. But if you're doing it open or if you're doing even robotically, try to pay more attention towards preserving the ureteral blood supply, which actually there is blood supply coming from the sides, from medial to lateral and lateral to medial, as you go distal around the ureter, but there is also blood supply running in parallel. So make sure that parallel blood supply remains intact. You don't do a lot of ureteral dissection. Unfortunately, left side, you have to do X-ray dissection. So make sure that you don't over dissect on the left side. You make sure that your edges are bleeding. That's an easy, cheap way to find out you have got your anastomosis will be all right. The other techniques that have been utilized, like in minimally invasive approach, you can use Firefly technology, ICG, and there is also a SPY camera available for open techniques as well. You can give IV ICG and assess with the SPY technology to see if the ureters highlight and demonstrate adequate perfusion. So that can also be utilized to make sure that you have got good perfusion of the ureters at the time of the anastomosis. How to do the anastomosis? I think you should be very liberal with your enterotomies and also with your ureteral spatulations. Make them decently wide. Do a mucosa to mucosa anastomosis. Make sure that you do appropriate mucosal approximation. I personally do sort of a tension relieving stitch. If you can see on the right hand side, there is in the diagram, you can see a stitch which basically goes a little proximal to the spatulation or the apex of the spatulation, and sort of aligns with where the ureter is going to sit on the bowel on your anastomosis. So try to do that. That relieves the tension a little bit. but it's a very sort of a weak stitch, so doesn't hurt to put that on. Then the type of anastomosis, there is no difference between interrupted or running. Both have got their merits and demerits. There's no clear differentiation. I tend to do a little bit of interrupted stitches to keep the apex in place nice and well, and then run the anastomosis. So my technique is hybrid, but running, sometimes people say, is more associated with ischemia, whereas interrupteds can lead to more leaks. So, but there is no one best or preferred way. Either of them are okay. The old school recommendation is to do it over a tube, a drainage tube, like a single J, double J stents. It's 6 to 8 French, but there's a lot of recent data coming out, which is sort of pushing towards a stentless anastomosis. And we'll talk about that in a second. The way you do the anastomosis, because it's an oncological operation, you should try to focus doing it more a Bricker way, which is 2 separate ones, versus the Wallace. There are overall similar complication rates, but there is some studies have reported less stenosis with Wallace, maybe because there's wider plate and less of ischemia. But from an oncological standpoint, it should be avoided because one ureter can choke the other ureter as well if there is any recurrence. So this is a rather older study, but it is out of Memorial. They looked at about 77 patients with stentless anastomosis and about 280 patients with stented. They included both neobladders and ileal conduits. And I think the biggest fear that we don't want to skip a stent is that we are worried that there might be a urine leak may happen. Somehow we have a feeling that it'll prevent a urine leak from happening. But interestingly, in that study, the urine leaks were just about 1.3% in the non-stented group and actually higher in the stented group. But clinically, what improves is, clinically, what actually favors us is that the risk of urinary tract infections were significantly less, and also the risk of sepsis was also low in patients who had a non-stented anastomosis done. And on both multi and univariable analysis, ureteral stent placement or use of ureteral stent was associated with higher odds of developing a postoperative complication. And as you can see, the sort of complication curves here, non-stented groups had fewer complications ureteral complications compared to those who had a stent in place. So there is a trend of doing a non-stented anastomosis. I think there is one NSQIP data just published like a few days ago from the US, and they said that the non-stented anastomosis, which was about 10% of the NSQIP population, they did not have any inferior outcomes. So there were non-inferior outcomes reported. So there is data available that sort of suggests that you can skip a stent if you want. If you skip a stent, then I would strongly recommend that you should have a Foley catheter draining your conduit so that you have adequate maximal drainage, and of course you put a pelvic drain as well. So omitting a stent can actually prevent some post-operative complications, like infections were one of the most common complications after cystectomy. Ileal anastomosis, I think is stapled or hand sewn. They don't have any significant difference. Make sure you have got adequate blood supply to the segments, not only for the bowel, but also for your conduit. Sometimes you can leave a long stay stitch on your anastomosis, and after a while you can pull the anastomosis and give it a quick look, make sure it has adequate perfusion and nothing is dying out. Your size of the enterotomies or the anastomosis should be at least 2 finger breadths wide, so that you can have a decent donut. Keep the water under the bridge. That means the conduit should be below the level of the enteroenteric anastomosis, so pay particular attention to that. And if there is a irradiated bowel, try to avoid those bowel segments. But if not, then try to cover the anastomosis or the butt end of the conduit, your staple lines. If you can excise them, fine. If you can imbricate and bury them, fine. But maybe environmental covering would be also helpful in prevention of any issues with that. I spoke about this at the PAUS meeting. We are doing isoperistaltic enteroenteric anastomosis. We usually see return of bowel function on day 3, like clockwise. I don't have any data yet to prove that it's superior to the standard anastomosis. You can also encounter some issues at the time of stoma creation, so pay particular attention. Try to avoid that kink, as seen in here in the Campbell's picture, but try to avoid that because that can also cause some stomal stenosis and ischemia and other complications. Always try to do it in the standard fashion. I do fascial stitches, and then I do the 3-point stitches to make sure that you can rosebud the conduit appropriately. Sometimes in patients with thicker mesentery or a thicker abdominal wall, some of my partners, I haven't started doing it wholeheartedly, but some of my partners pre-evert the stoma, rosebud it inside the belly, and then bring the whole thing up out to the skin. So that's another way to do it and prevent stoma-related complications. So other intraoperative factors that you have to consider, especially with regards to anesthesia, that try to keep the patients euvolemic. Do not underhydrate or overhydrate these patients, because bowel edema can come in if you overhydrate these patients, and that can cause some ileus in the postoperative period as well. Try to avoid hypothermia. Use appropriate postoperative pain killers so that you can avoid the use of narcotics. These can be, you can use an epidural, you can do a tap lock, you can do a tap catheter. If you're making a big midline incision, you can also use an incisional anesthetic with an on-cue pump that can also be used. Postoperative pain control, we on a very routine basis use IV Toradol or Ketorolac, along with IV acetaminophen, and switch them to oral and try to avoid narcotics. And these are also part of the ERAS protocol guidelines. Post-operatively, NG decompression is no longer recommended, not even in open cases, I'm assuming. I don't know if any of my open colleagues, open surgeons are doing that. We usually leave it because of the steep T-berg. We leave an OG tube and pull it out at the end of the case. We only run the antibiotics as per AUA guidelines just for 24 hours. There is some data about patients who already have, say, for example, indwelling Foleys, nephrostomy tubes, or stents, that if a single dose of diflucan can also prevent from some fungal infections in post-operative period. So we have routinely started doing that. The key factor here is early ambulation and or oral intake. So try to ambulate patients sooner. Patients who get robotic surgery usually are better with that. So we try to put them into the chairs on day 0 to day 1. We encourage them to ambulate in the next couple of days. We start with ice chips and sips of water early. Then we progress to restricted clear liquid diet, and if they tolerate it well, we proceed to unrestricted, followed by full and regular once they're passing gas and have bowel movements. We do stimulate the gut with rectal stimulation. We also give them oral stimulation as well. We continue the NTRAC till the return of bowel function, so you can use that as well. I use the IV fluids in a very judicious way. We do start IV fluids initially, but as they start tolerating orals, they've got adequate urine output, we start decreasing the IV fluids again to limit the development of the bowel edema and volume overload. Then pain control, as I mentioned, is very important. Try to focus more on non-narcotic pain control. GI and DVT prophylaxis is also is started. We encourage chest physiotherapy as well. So these are the key postoperative factors, which are also part of the ERAS protocol, so you can address them from that as well. As I alluded to,
yes. Kindly conclude.
Yes, I think there are a couple of more slides, and that's it. Postoperative ileus is a very important complication that we talked about. So be aware of that, and I don't need to teach you how to manage that. But one thing I want to highlight here, and Dr. Hamad has already given a talk previously through this forum on extraperitoneal radical cystectomy. This is a rather new approach. This is a comparative analysis of transperitoneal and extraperitoneal approaches for radical cystectomy, and clearly did demonstrate that the events of postoperative ileus were significantly less in patients who had extraperitoneal approach. However, one size does not fit all. You have to be very, very careful with what type of patient you select for this approach, and I think it should initially only be practiced into expert hands, as Dr. Hamad has been doing this. So that's I would suggest. So just a few checkpoints at the time of discharge. Another important thing to highlight. In the West, you can use sub-Q heparin. Sorry, in the East, in developing nations, if Lovenox is more expensive, but we do have data on oral prophylaxis as well with Eliquis, and it is equally safe to be administered. So in conclusion, complication-free radical cystectomy is only a dream, but with proper patient selection, good experience, high volume centers, a consistently same repetitive surgical technique, I think these can be tailored down and avoided. A structured care pathway, multidisciplinary team approach can be a major predictor of success and prevent postoperative complications. Thank you very much for your attention. And interestingly, I'll tell you that my fastest home discharge was an 83-year-old who went home on postoperative day 3. We'll be glad to take any questions now or later.
Thanks, Johar. I think in the interest of time, we'll keep questions in the chat box, and you can address these questions as they come on the chat box. We'll see if we have time at the end. We can ask all our faculty tonight to address those questions. With this, move on to the last part of today's webinar. And may I invite Dr. Rehan Khan, who is a consultant urological robotic surgeon in Lanarkshire in Scotland, to please share his slides. Rehan is going to talk about how to manage these complications. And as Johar mentioned, it's likely that 1 in 3 patients would have significant complications, and their management is an important part of a cystectomy surgeon. Thank you, Rehan. The floor is yours.
Thank you, Professor Hamad. Can you see my screen?
Not yet.
Okay, just 1 second. Apologies for this. I mentioned to Professor Athar, I'm traveling at the moment and there's some issues with my tech. So let's see, any luck now?
Yeah.
Can you see my screen?
Yes,
yeah.
we do.
Yeah, okay. Let's see. Right, thank you very much for this invitation. Professor Hamad and Zishan asked me to sort of present to this August sort of group. My name is Rehan Khan. I'm a urologist in UK. I've been asked to talk about radical cystectomy and how to deal with the complications. It's quite a difficult gig to follow Nadeem Bhai and then my friend Sarfraz and Johar after their comprehensive presentations. But I'll try and give you like a real world experience of what I do as a surgeon. I have no conflicts for this presentation. I've got quite easy to go through slides. Hopefully all the delegates can relate to this, and hopefully I can give them some take-home messages. So I'll talk about complications. I think Johar has given a very, very comprehensive overview of that, and also he's touched upon most of the things that I'm going to talk about. So there will be some overlap. But again, the beauty of such courses is that sometimes the repetition helps you reinforce the message that you want to take. And I'll talk things that I do in my practice. First thing I would say is why did the program directors, Professor Hamad and others, thought that we should have 2 talks on complications? And what I'll say to you is, as a urologist, as a consultant for last 10 years, and as someone in urology for last 20 odd years after my graduation, radical cystectomy is a difficult operation both for the patient and also for the surgeon. And a lot of it is to do with the complications that come with it. And in urological surgery, this is one surgery which has so many complications that you really need time to think about these. You really need to go through what you will do if you face any of these. And my approach towards that is of mitigation and how do I manage my complications. So just some data. If you look at old literature, it talks about data prior to 1990s in radical cystectomy, talks about a mortality rate of which was very high, maybe 3 to 15%, and potentially morbidity was a bit low. Now it might be a reporting error, but I guess most patients who did not have a morbidity, they fell into, well, or were not reported in the morbid section, they probably fell in that mortality section. So that is why probably the morbidity is reported low in that data. More recent data, it talks about mortality in the region of 2 to 4%. However, in the older age group, octogenarians, mortality can be high. There are other risk factors that can dictate that. And morbidity is up to 60 to 70%. So what I say to my patients in my clinical practice is, and my first thing to these patients, certainly in a UK practice where you actually can be quite open and upfront and actually have to be very, very honest with the patients, and they would take all these things very, very openly. I say to my patients that every patient has one problem or another after cystectomy. Let's hope you have a small problem and you'll be fine. However, if you have a big problem, it can be really, really serious. And if it is very, very serious, unfortunately, 2 to 4% of people don't survive. Now, what's the surgical factors behind this? And I know Jawhar and Sarfraz have very eloquently talked about, how many parts this surgery has. This is not like, a robotic prostatectomy or a radical nephrectomy, which only has an extraoperative part where you remove the tumor and that's you done. We have so many parts: remove bladder, remove lymph nodes, deal with the bowel. But I have a different view on this. I mean, when I talk about this surgery, I say we're actually, as a urologist doing this operation, we're doing urological surgery. We are dealing with complex vascular, surgery in terms of DVC, and not only that, we're doing significant, lymph node dissection on major pelvic vessels. So you're probably closer to these vessels and trying to preserve them more than a vascular surgeon would, because he's dealing with disease vessel and he's actually just excising and putting grafts and stuff. I think that is then followed by significant GI surgery. We deal with small bowel and other parts of bowel more than any other surgeon would deal with another area of expertise. And we do small bowel resections, anastomosis, and then urothelial anastomosis. Then we also are gynecological surgeons. We're removing gynecological organs as a part of radical surgery. And lastly, we're also reconstructive surgeons. So in many ways, as a urologist, when we're doing this, we're at least doing like 5 different types of surgery here. And all those surgeries come with a risk, and they bring the morbidity and mortality associated with this procedure. Now, generally, I think, again, Jawhar has alluded to this. There are a lot of patient factors. A lot of detail has been shared already, but these patients are smokers. These patients are in older age group. They're immunocompromised for either the tumor factor reasons. They're generally because they develop tumor because of immunocompromise as well. And also a lot of them, well, a proportion of them would have had neoadjuvant chemotherapy. And we basically hit their system so hard with all this chemo just a few weeks before we are going to subject them to major surgery. So that is again not on our side. So these are the patient factors which which dictate this. Now, a lot of our patients are smokers or have cardiopulmonary disease, so they don't have that physiological reserve, And as Jawhar said, I also do this in my practice, that I see my patients at least twice in the lead up to surgery, and I actually give them some targets of if they're already someone who does exercise or is a gym goer, I give them a target to increase that. I tend to do quite a generic, but something that works for me. I mean, in my hospital, we have like 5 floors. So I take them right to the basement of the hospital and ask them to go up all those flights of stairs with me. And I see how they're coping, how their cardiopulmonary reserve is, give them some exercise, ask them to come back if they don't pass my test. And in terms of their reserve, I talk to my patients and say, look, if you were setting out on a long journey, and this is a long journey for patients, and you get into your car and you see that your fuel gauge is on the ember or it's about to finish, would you risk that, okay, I'll just drive away and I'll find a petrol station when I need to and just risk it? Or would you say, no, I need to get to the petrol station and fill this tank up before I leave? So this is what I say to my patients. You need to fill the tank up before this long journey. Now, I think how to manage complications, I have a different take on this. In my practice, management of cystectomy complications starts at the day of the TURBT. If I see there is a muscle invasive disease, potentially, I'm already thinking, is this the right patient? I'm going to ask my anesthetist, what's the ASA here? Is this patient, do you think this patient might be fit for cystectomy or not? And I think that two-way conversation with your team and with your anesthetist should start early, because they've got muscle invasive disease. Well, mostly you can predict you will find muscle invasive disease, or the patient is heading towards a cystectomy. So you need to start early. And there are many factors you need to take into consideration. Age is one of them, BMI, other comorbidities, previous abdominal surgery, smoking and alcohol status, their nutritional status. And I think in my practice, patients' attitude toward rehabilitation. I mean, Jawhar has very eloquently talked about ERAS. A lot of it is to prepare these patients and not just, deal with the problems afterwards. You have to prehab them, and there are various protocols out there. You can adopt one which works for you. I've got my own sort of prehab leaflet we have developed in our center. And that includes a number of steps the patients have to do and make sure they've ticked all those boxes of stop smoking, try and lose some weight, exercise, do power walk 20 to 30 minutes, 2 to 3 times a day, at least do foot flaps, do deep breathing exercises, and take a multivitamin mineral. And also we talk about other things of getting psychologically ready for this surgery. Talk to your family, talk to your kids, make sure you've got a will in place. I mean, and we say that in a way to give them a real life idea that this surgery is serious, and some patients cannot survive. Now, the other thing, my approach is that if the patient's not fit at that particular point in time, I look for other things. Could there be an alternative option? Could I give patient some more BCG, a second induction course? Could I drive them towards radical radiotherapy and with a view to getting them fitter? And if they then recur and need a salvage, they can come back. I had a patient whose HbA1c was suboptimal. His HbA1c was close to 90, 95. And I said, look, it's not really safe to take on bowel work, certainly, because you're likely to develop some complication, have a bowel leak, and that could kill you. So that gentleman already had nephrostomies in. So in that case, I did a cystectomy, node dissection, and left him with the nephrostomies and let him get his diabetes under control. And I did a staged ileal conduit later on him. So that is something that you can always do. I think as Jawhar has said, there are some pre-operative interventions, importance of having a good surgical team. You need to have senior clinicians in this team. This is certainly not an operation you would want to do day one, completing your, even your fellowship training. You need to be working with peers, consultants, registrars. You need to be working in a big setup, which has, and I mean, there is data out there that surgeon volume as well as the center volume does affect patient outcomes. You need to work closely with your aesthetic team, and as I alluded, nutrition, BMI, management, and giving them. I tend to give them Ferinject if they are anemic 2 weeks pre-op, and then post-op as well if required. I'll probably skip through this. I think John's already alluded to these. I think your antibiotic and antifungal prophylaxis will vary depending upon your area, your own sort of discussion with infectious disease or microbiologists, but certainly something to think about. Again, I think surgical technique has been talked about in quite a lot of detail in the previous talks. What I say is prepare well as a surgeon, go through your cases, maybe discuss them in the MDT a week or two before, go through the pathology, radiology, anticipate challenges. George very eloquently said he's already spoken to his colorectal colleagues. That's the right thing to do. You don't want to be stressing out on the day and looking for someone to help you if you're in a problem. Surgical technique we have talked about. Again, this is a multi-organ, multi-speciality operation. So prepare well, train well, prepare well, and do well. What I say to my trainees is that you need to go for low-hanging fruit when you're doing surgery. You go for you can have a scheme of what you want to do first and what you want to do next, but if you're finding it difficult, go for something else. And if that something is allows you to get some space, get some mobility. For example, Sarfraz said, go to the right ureter. But if you've got a massive, big right-sided tumor, go to the left side, get some mobility, get some space, and then come back. So always remember, go for low-hanging fruit. You don't need to aim for the fruit at the top of the tree. Go for the smaller bits first. Now, the other thing I say to myself and my trainees is, in this type of surgery, sometimes slow is fast and fast is slow. If you go too fast, you might have a complication. Then you are going around in circles trying to get back on track. And you need to know which bits you can go fast and which bits you need to go slow. I mean, dealing with pedicles, dealing with DVC, go slow. Preserving the sphincter for neobladder, go slow. Things like once you've developed the pedicles and you're doing the lateral sort of trenches to go to the pelvic floor or dropping the bladder, those are the bits you can go fast. I think again, a lot of this has been already dealt by what Johar has said in quite a comprehensive presentation. In my practice, I do give them antibiotics. We are starting to think about antifungals. We actually have a very strict policy. We ask them to stop smoking, and go on to alternatives if needed. Adequate hydration, yes, as intra-op, you want to be euvolemic, but I think post-op, I tell HTU that I want them 700 to a liter positive. Chest physio, early mobilization. If I can't get a physio to come and see my patients, I actually go and do it myself. If they can't mobilize him, I actually get them up on day one and take them around the unit. So there should be no shame that you have to do it, or anyone on your team as a medic has to come and see these patients and get them up. I think that saves lives, you know how much hard work they've gone through and you've gone through to do this. So don't undo that by not seeing your patients and mobilizing them and making sure they're mobilized in the post-op period. Again, some generic things about use hemostatic agents, energy devices, cell saver can be used, blood transfusion as required. Again, it's been alluded before. I do stent my patients. I do leave drains in. I'm quite conservative in taking them out, slightly against the ERAS protocol. I tend to leave my drains in for a bit longer, so that if there is any leak or lymph leak or urine leak, then you have managed it and you're not having to chase an interventional radiologist to put in afterwards. And sometimes if the leak is really significant, I've put nephrostomies in to divert the urine, and that has saved me from having to go back early for any anastomotic leaks. Ureteroileal anastomotic strictures, again, you can divert with nephrostomies, and you can plan redo surgery in a staged fashion. Lymphoceles, again, Jawhar alluded to this. I think technique should be good. You should clip the big lymphatics proximally and distally, more importantly distally, because that's where the lymph's going to come up from. There's techniques described as leaving opening into peritoneal cavity to allow the absorption. As I said, I leave the drains in for slightly longer. And you can put in percutaneous drains if they present later. GI complications are the one which actually are the most significant for patient recovery point of view. We know ileus is very common. Thankfully, fistulas are less common. I think my practice, I actually am a bit, more or less what Jawhar mentioned about feeding protocol. But if I have any inclination, the patient's is developing a distending abdomen or feeling nauseous or going to vomit, I just put in an NG, put them on parenteral nutrition. I've never regretted that. If you do get a real small bowel obstruction or internal hernia, then you have to obviously intervene. And the management for that or the fistula is the usual, nutrition, control sepsis, divert and drain. And you go back in a planned way, and if you ask for help from a colleague. These are some of the long-term complications. You need to be aware of managing the B12 and folate and bicarbonates replacements. Renal impairment can happen. So again, you need to manage that and have an open eyes for that. And stoma complications, manage them in an MDT approach. Now, one thing that I believe very, very strongly in is good communication. Now, one example of that is that I speak to these patients. I encourage them to bring their family, their kids to come and talk to me, so that I develop that rapport. So that, because these patients will have complications, and then you don't want to be facing a family which say, and someone says, "Oh, you never told us this," because you never invited them to your office or your clinic. I actually call my patient's family during surgery, or ask one of the OR staff to call them to say, yes, everything is going fine, or no, we're having some problems, we're working away. So, that is what I learned from one of my trainers. We would call the family every 2 or 3 hours, or certainly once or twice during the operation. Good communication with HDU nursing team, stoma team, physios, district nurses, and the primary care team. In the interest of time, this is my last slide. So in my mantra, the best way to manage a complication is not to have them in the first place. And a lot of this you will learn. You can identify what to take on, what not to take on, what you can mitigate pre-op. Now, cystectomy, you will not avoid a complication. It's not like you will never have a complication. Every cystectomy will have a problem or another. Hopefully, what will happen will be a minor problem. You need to become strong enough and embrace your complications as a cystectomist, and you do best you can to achieve the best outcome for patient. Now, also remember, not all your patients will survive. It's not on you. As long as you've done an honest job and good technique, you've done your bit. Some patients do have their own patient factors, their disease factors that they might not survive. The thing you want to do is minimize those numbers in your practice by meticulous patient selection, careful perioperative care, and a multidisciplinary approach if you have a problem. I'll take any questions if there are, and I'm sorry, I might have ran over a little bit.
No, Rehan, you finished well in time. Thank you very much. I am really grateful to the 4 experts, and they are all leading surgeons. They have done so many of these procedures, and whatever they've talked about this evening is extremely important for you to understand. There may be some opinion which are different for different surgeons, but then this is a complex surgical procedure. And as Rehan mentioned, it is not one surgery that we are performing. We are looking at various organ systems, something that we don't deal with on a regular urological trainee. So it's important that we take care of this patient comprehensively. most of the questions have already been addressed, and we have just short a little time. So I would suggest one last comments from all our four speakers as a message to our junior who are in the process of starting or have done few cases. So start off with Nadeem, you, and then we move on to our other faculty members.
I have only one comment, Professor Hamad, that I think when I came to Pakistan just 2 years ago, my idea was to bring technology back home, and I was excited. But then what I've realized that we are far behind, and now I focus mainly not on the robotic surgeries, not on high-end procedures, or not on things like that. Yes, I'm collecting data, but my emphasis, my focus is on public and professional healthcare people, uh, healthcare awareness campaigns. So I'm trying to hold the seminars, symposiums, and I do talk to people. I go to universities to hold seminars so that I can convince people to present early. We diagnose patients early, and we can have an uneventful procedures. And the same, we are trying to train specific and interested and, motivated trainees to get into oncological part of the urology and to learn this procedure, well, and just, to focus, because I've seen people just, they're focused on the stone surgery and just one single procedure as a PCNL, and there are very few people doing only andrology. So why not oncology, and why not, cystectomy? So my focus is to bring up, the fresh blood trainees who can focus on increasing awareness. And I think only awareness would bring us this disease early and to manage it well.
Thank you. I think very aptly said. Sarfraz, you made a brilliant talk on robot-assisted radical cystectomy. And as Nadeem also pointed out, it's important that the surgical procedure be done well, whether it's robot-assisted or open. Any final words?
I just want to give one advice to all the trainees or all the surgeon, which is an early part. We all focus, like we all love to do operation, but just try to, especially for any complex procedure, try to follow the journey of the patient. You need to focus in early part of your career, the pre-operative journey of the patient, surgical technique, and also the post-operative follow-up. Often, like, we are distracted to learn the technique, but don't see this pre-operative and post-operative outcomes. So whenever you do operation or involve in any patient, so I will advise just to follow the journey for years, and their journey will make you more wiser and help in learning in future.
Thank you, Sarfraz. Rehan and Jauhar very comprehensively covered the complication bit. And what is coming out very clearly is that the sooner you mobilize your patient, you'll be able to decrease the chances of two common complications, which is related to the gut, as well as the atelectasis or pulmonary complications. So that's extreme, and on obviously DVT as well. So this is extremely important. And what also they have pointed out, and I'm very impressed with Rehan's comment about his involvement with this patient. So these are depressed individuals with a cancer and extensive surgery, which is a life-changing experience. The way he described how he gets involved with the patient and motivate them to come out of this difficult surgical procedure. So any last word, Jauhar, and then Rehan?
Yes, sir. I think the key factors have been very eloquently identified and addressed. Once again, I will reiterate what Dr. Sarfraz Ahmed said, and also Dr. Naseem Nusrat, is that this is a complex surgery. You do it open, you do it robot, you do it lab, whatever it is. It's a complex surgery, so you have to know the entirety of the procedure, the preoperative, intraoperative, and postoperative management. You cannot pick and choose that I will just operate and the rest will somebody else is going to take care of. No. And the success of your surgery, it is entirely dependent on what you do beforehand and what you do afterwards. So I think knowing it in comprehension is very important. And I would just this discussion going on in the chat box. Yes, I'm not arguing that you should not learn how to do the surgery. Yes, we can teach you the steps as well with videos and everything, but knowing the the details is very important. Example is pheochromocytoma. If you see a pheochromocytoma patient, there is so much that has to go pre-operatively in the management of that patient, let alone just intraoperatively or just doing the adrenalectomy. So and of course post-operative as well. So it's almost the same thing. It's a very extensive, very complex surgery. Lots of complications can happen. So be extensively involved in knowing how to do this. And Dr. Rehan, like he mentioned, that you have to be personally invested into this. So in order for it to be successful, your personal investment is very, very important. So and we are here to teach you. If you want to learn any tips or tricks, we are here.
Thanks, John. Rehan, one last comment.
Yeah, at last I've got this working. No, look, I think this is a great forum. I think all the delegates here should, they have had experience from in fact, 4 different parts of the world, talking about a really, really complex operation. I think I really enjoy doing cystectomy in spite of all the challenges. I mean, it gives me that professional, satisfaction, because these bladder cancer patients are the ones who, in some ways, benefit the most from surgical intervention. I mean, bladder cancer is a killer, as we all know, and if you can do this and provide this service to your patients, you will definitely make a difference. My one point to everyone would be, make sure you've got a mentor, and make sure you work with them. There is no shame. I actually, till now, I'm actually mentoring one of my junior consultant, who came in sort of 5 years after I started, and he still comes, and we think that doing it together with senior people, it makes the world of difference. It's a long operation. It's like 5 different operations in one. If you have a team, you will have a good day. If you have a team, your patient will have a good day. And also peri-op, they can help you with the care. So make sure you work as a team and have a mentor with you.
Thank you very much, gentlemen, lady. And so we will see you back again in 2 weeks' time, and where we're going to talk about some of the other aspects of surgery of radical cystectomy, the lymph node dissection, etc., the diversion, and also if there is another way of treating patients with muscle-invasive bladder cancer. So thank you very much, and I hope you a very good weekend. Thank you.
Thank you very much. Thanks, Dr. Ahmad. Thanks, everybody.
See you later.